Okay, everybody, welcome to our Athletic Training Journal Club for the month of May. This month, we are going to look at sports-related hand and wrist tendon injuries from Dr. Patel, Allison Taylor, she's an OT, Ronnie Colley is a PT, and Mindy Nelson has an AT. So I'll go ahead and push it over to you guys.
All right, guys, how are you? I know everyone's muted, but I want to thank everyone for helping me put this slideshow together, especially Mindy. And feel free to chime in. I know with Zoom, it's always difficult to know when to chime in, but feel free to chime in to ask questions. I know it's always hard to make it seem like it's in real life, but we're just going to kind of touch on some really basic hand tendon injuries. I try to be more regarding the sports related or acute as opposed to kind of chronic, as there's always some sort of chronic component to a lot of these things we're going to discuss. We can, I guess, move to the next slide. There we go. So, you know, tendon injuries are really common in the hand. 33 out of 100,000 people. Second most common injury in the hand. And most of the time, I mean, for what I deal with, we see a lot of lacerations and open related tendon injuries. Obviously in sports, a little bit different. You know, that's good and bad. Obviously with open injuries, we always worry a significant amount of soft tissue involvement, and that can affect the motion. So with closed, obviously the difficulty can be getting a good examination and knowing obviously what's going on. So, you know, I encourage everyone to not only examine immediately after the injury, but make sure that you follow up and do a good examination. Even just watching the patient as they move their wrist or move their elbow is important because of the tenodesis effect in the hand. So that is a good thing to do. Next. So, you know, first off, jersey finger. So zone 1 injuries are about 4% of the tendon injuries in the hand. The jersey finger usually occurs because the flexor digitorum profundus is in tension, and then you get a forced hyperextension of the DIP joint. Obviously, as we know, commonly in football, rugby, finger being caught in the jersey. Usually presentation is obvious in a lot of cases, that like the picture there shows that the DIP joint is extended. They flex the PIP joint and the DIP joint stays extended. Always here important, sometimes because of pain, difficult to get a good exam or immediate swelling. Tenodesis effect is very good for this, especially after the pain goes down. Sometimes you can actually inject the finger and do a lidocaine block, which I've done obviously in the clinic, usually more often, and then get a good examination as their pain goes away. And then you can get, you know, kind of a more, you don't have to have them follow up multiple times if you're still questioning it or worrying about it. Next. So I think it's number one, important to examine, and then also, if, you know, I'd like to get an X-ray always, because there can be a bony component to this, and we're going to go into the types of it in the next slide here. But you always are worried about an avulsion fractures being part of it. The ring finger is involved 75% of the time. There's a lot of theories, a lot of thought into why. Obviously, when you grip around something, your ring finger is usually the longest or most sticks out the most. That's in 90% of people. Okay, so 90% of people, that's usually the case. There's also thought that the FDP attachment in the ring finger is the weakest. There's also thought that the lumbrical, bipennate lumbrical of the FDP tendon kind of bunches up in the palm of the ring finger, doesn't allow the excursion of the FDP. So when you get that forced, you know, kind of bump extension, it snaps easier. Okay, so I don't know if I believe 100% in all of them or any of them, but you know, I think that there is some good studies regarding all of them, and so you know, the ring finger obviously we know clinically is the one that's always injured. So always be on the lookout when you get a ring finger injury. Next. So different types. The key thing to remember here is it's in reverse order of what you think. So the one when the tendon is most proximally, that's type 1. Type 2 is right between kind of the A2 pulley and A3 pulley area. Type 1 is usually proximal to the A1 pulley. And then type 3 is distal and just hangs up right there at the A4 pulley. 4 and 5 have bone involvement. So you'll see those on x-ray, obviously clinical exam. They can't flex the DIP joint and you see bony avulsion. You do have to always be on the lookout sometimes for, these have been further subcategorized if you keep going in modern times, but where there's a bony avulsion as well as a tendon injury together, which can happen. More rare. I don't typically get MRIs on these unless I'm kind of in the gray zone, which is pretty rare after examining them and getting an x-ray. So, you know, as you'll see kind of in the example I have for surgical repair, that you kind of know where the tendon is going to be and you kind of follow it to find it. So I don't know how an MRI really helps me that much. This is, in my mind, in a young athlete or a young person, definitely surgical indication, 100%, even not in a young person, it's a surgical indication. I have had patients who have decided not to have these repaired, okay? And that happens from time to time, especially when you have this a small finger or isolated FDP of another finger that they don't think is as important. So next slide. So surgical treatment, you know, our thought process for me has evolved from doing something where you pull the suture through, which can be over a button, over gauze, even over the nail plate, to then adding anchors, and even studies that show both anchors and pull through of some sort. As you can imagine, from a strength standpoint, and an early motion standpoint, we are always worried because we want to get these patients moving fast. So I always like to do an anchor as well as a pull through of some sort. I just tie over the nail plate, usually with some gauze, to get them moving faster. The key here when you're doing an anchor, as you can see in this bottom left picture there, is that the anchor is put in at a 45-degree angle. And that has been shown to be stronger. It also, doing some studies show 2 smaller anchors is stronger than 1, which is almost like common sense, but it's true. Also having an anchor, the other benefit of an anchor, it actually allows you to do more of a locking type stitch that locks into the tendon, because obviously when you do a pull through, you have to have both ends of the suture come out of the skin or the nail plate and tie over. So given those kind of, you know, I think an anchor definitely helps. I usually, like I said, try to do an anchor as well as a pull through of some sort, which is pulling the suture over the nail plate. And for me, I usually use a small piece of gauze and just tie it over there. In my experience, I did button at the beginning, but I feel that most people don't like having a button at the end of their finger, but it's always hard to convince someone that they're going to keep this in for about 6 weeks, but usually they're pretty compliant with it. So next. All right, so this is actually one that I just did last week. Football player and had a jersey finger. Actually, this was almost he presented to me, I think, about 2 or 3 weeks after the injury. This is during surgery. As you can tell, the tenodesis effect, kind of obvious there. The ring finger compared to the others is in an extended position of the DIP joint. This was a type 2, and I have already kind of pulled the tendon through. In that second picture, you can see the suture in it, just as I used to kind of pull the ball of that tendon through and help me go under the pulley system, which you can kind of see in the proximal aspect of that incision. You can see the pulley system there, and I've pulled the tendon through each of those, and that can be pretty tight. So one of the key things here is getting to these early so that the pulley system doesn't constrict down and you can get that tendon through, because that can be an issue. Then you have to dilate the pulley system, or sometimes do a 2-stage reconstruction if you don't feel comfortable getting it. So next. And then here, just showing the pull through that I've done, which is through the nail plate and over a small piece of gauze. And I tie that Prolene over there. And then after the surgery is complete, now you can see the position of the finger and how it is in a flexed position with good cascade as compared to the other fingers. So good holding of the repair.
Dr. Patel, question
Yes.
for you. What type of home care instructions do you give them whenever you're using the gauze technique to keep it clean and dry for that duration of time?
So number one, unfortunately, I don't let them get this wet. So, that is, they can clean around. So once they'll go into a splint. And then we're about to talk about, I think, post-tab rehab, but they can clean around the gauze with a little hydrogen peroxide on a Q-tip. I don't really let them get the tip of their finger wet. I'll tell them to cover it either with like a tegaderm type of, or put another piece of gauze and a tegaderm over it, or another piece of gauze and a bag over it, and then they can take that off. The hardest thing is getting this snagged on something. So I have had to, the gauze get wet, nasty, and then we just have to take it out. And that's okay. Like I said, you can tie this directly over the nail plate as well. So it's not, the studies have not necessarily shown that having a button there or gauze is necessary. You can do it over the nail plate as long as you exit a little distal enough where you're not affecting growth of nail or nail deformity is what you're trying to avoid, right? So next. So post-op rehab, this is just, 2 basic articles that really have defined kind of early motion and a true active protocol. Just kind of wanted to throw them out there with you. I know it's probably more than you want to read up on, but it goes into some of the science and studies behind it and the techniques. But next. And this kind of protocol, the true motion or early active motion, I use for kind of zone 1 and zone 2. Doing wide awake surgery has really helped us kind of develop these protocols and really, I like to do that as much as possible. Sometimes I will tell you it's patient dependent, especially getting young teenage patients to cooperate is more difficult than you think. But wide awake is nice, and you can get a good repair and they can be awake and know everything going on. But even if I'm pretty secure that I have a good repair, especially when I use an anchor and a pull through, I'm very quick to start this true early motion protocol. So 3 to 5 days after surgery, they start dorsal block splint, start passive movement fully of the finger, and then active kind of halfway from making a fist. We're just trying to get some gentle mobility and early motion. Quickly, we move to next slide, which is starting to get some of that tenodesis effect with synergy, moving to a short splint so they can move their wrist now, and then allowing them to start, fully flexing pretty much as they tolerate, as they extend the wrist there, okay? So that's the movement that this will allow, now freeing up the motion of the wrist, basically. So stop splinting around 6 weeks, 6 to 8 weeks. Then we start splinting for certain contractures. We splint if we feel that there are lags, meaning that, hey, I can't get it extended, I can't get it flexed. So we try to start correcting those things, add strengthening. 8 to 12 weeks really is kind of the return to play. You know, obviously, depending on position, what they do, can we have it splinted? Can we have it casted? Yes, I have a little bit of leeway, but really I tell most of my athletes 3 months you're looking at before I'm going to let you go. And I think that's a good rule of thumb, especially with this. So this is re-ruptures is a thing that can happen. I can tell you, you know, in Jersey fingers don't see it as much. Obviously, when we're talking about zone 2 injuries, that is a very common thing that we discuss. Overall, good outcomes with Jersey fingers, especially if you catch them early, and especially in the young patient. You know, I think that they get excellent motion. So next. Any questions about Jersey fingers before we move ahead? All right, so mallet fingers. Everyone sees mallet fingers. Forceful flexion of the finger is the typical mechanism. Any injury, I have even seen it where there isn't an injury, and you know, there are people perceive that as no injury, and they reach down, grab something out of a bag of balls, and they look at their hand, and I've got a mallet deformity. So a lot of it just has to do with the force of the tendons as you are grasping. So it is typically a tendon injury off the distal phalanx. Yes, there can be fracture associated, which we'll discuss a little bit here. Next slide. These are very usually easy to diagnose on examination. As you can see the deformity very quickly. I will tell you that I do encourage that everyone gets an x-ray when they have this deformity because there can be a fracture. And the biggest thing we are looking for is joint subluxation. When we are looking at the x-ray, if there's a fat fracture associated. If you read you know, the books, they'll say, hey, 30% of the joint surface could be a good indication for surgery. One of the biggest things we talk about is joint subluxation, and that's if the fracture causes the joint to droop down. And when we see that droop down, that's when we get more aggressive at either pinning or fixing if there's a fracture involved, okay? So non-operative treatment, use whatever you can to get that DIP straight and hold it straight. You need to move the PIP joint, and that is very important here. The other thing you want to always be on lookout for is hyperextension of the PIP joint, and we want to avoid a swan neck type deformity. The best thing for that is flex the PIP, flex the PIP, flex the PIP. And so I have a lot of patients that come in like this and have splint all the way from the MP joint forward, and that can be an issue if they present 3-4 weeks later. For me, no bony mallet, no bone involved, 8 weeks, full time. I tell the patient, take it out of the splint at 8 weeks, look at your finger. If you are happy with the way it looks, then nighttime only for 1 month after that, okay? And you can start daytime activity. If you are unhappy with the way the DIP looks, I will tell them they have, at that point, you do 6 more weeks of full time if you're unhappy. The likelihood is you are going to end up with about 10-degree droop, which is shown to be fully functional and not usually an issue clinically or from a day-to-day life standpoint, okay? surgery versus no surgery. As we get into this, has been compared in multiple studies. Non-op is always our choice for various reasons, but one of the biggest is almost 50 or greater than 50% complication rate, especially with skin issues, infection, loss of fixation, tolerating fixation in the wires. Those are big problems with surgical treatment. So unless we see the obvious, which is significant joint space involvement or the subluxation, I push people to treat this conservatively as much as possible. I have had a few people convince me for job-related reasons to have a wire put in it. I've had a musician do that. And so basically you put a wire through the DIP joint and cut it, obviously under the skin. They can use it more freely. I've even, knock on wood, joked that I guess if I had one, I would put a wire in it too, because I could still operate theoretically. So cut under skin. So, for career, that's another reason and indication that we will sometimes do wires. So surgery, the first picture there is truly a wire put in for holding the joint straight. I don't think that, I don't do that very often. It's a very small portion of an avulsion. There's no big subluxation. That's truly a wire without any blocking component. The second picture there shows a dorsal fracture with some subluxation. And that one I prefer to do a blocking type technique with the K-wires, which we use 2 wires, one to block the piece that's broken, so it is then pushed against the distal phalanx, and that's held in an extended position. Wires are left in for 6 weeks if possible. Sometimes patients can't tolerate it, we'll take it out sooner, but I like to do 6 weeks. Anchor technique is more reserved in my mind for delayed presentation, or if we are talking about someone that's failed conservative and really wants to push having surgery, which, like I said, I kind of talk most people out of it unless they have significant subluxation or the joint space is significantly involved. But that's where we go in, mobilize the extensor, place an anchor into the distal phalanx, and tie this down. This usually also ends up having a wire placed in it. Next slide. So 6 weeks basically is DIP joints held in extension. Once again, PIP needs to move. PIP needs to move. PIP needs to move. Skin is a big issue. So I encourage everyone, and this is just not even with surgery, but without surgery, to spend some time every day with your finger on a hard surface, to hold it straight, to let that skin get some air time, because that is the #1 complication of splinting, whether you treat this conservatively or surgically. And the thing that patients don't like, they always complain of, hey, a burning type feeling on the dorsal aspect. It's almost like an abrasion type of feeling of the skin. And the best way to treat that is air time. So that's hard to do, especially if they have it on all the time and just in a moist environment. Don't change it. Sweaty. So after games, spend that time drying it if they're treating conservatively. Get that skin dry, spend some air time, even use a cool hair dryer setting if you need to. But I think that's important because that skin can be a big issue. There's all sorts of, obviously, off-the-shelf splints. There's all sorts of splints that therapists can make that may be beneficial. A lot of it just ends up being what is comfortable for the patient at the end of the day. So 6 weeks and then weaning. I usually start strengthening about 8 weeks, adding slowly more function with the pinning and fracture. So questions? All right. macerated skin, as we talked about, airtime, cornstarch is a good thought. And then, as we talked about, working more aggressively after 8 weeks, so 8 to 10 weeks.
I have a question for you. I know that you said no passive range of motion to the tip, only active range of motion.
Initially, yes.
Okay.
Yep.
How long for that duration?
So basically that 6 to 10 week mark period, I usually tell them active motion. And then starting that after 10 weeks, you can start pushing it. So, that first 6 weeks, if we're doing surgery, then we're talking about in a splint or a bony mallet. First 8 weeks, if you're not doing surgery, and if we're just treating a true tendinous mallet. So after you stop the splinting period or after the wires are removed, if we're doing surgery, then at that point we are for the 2 to 4 weeks, depending on whether you're treating this conservatively or not. I'm telling them to do active motion and then really starting to push the passive more. I'll tell you on my bony mallets, if I see good healing and I'm happy with that, I will start that a little sooner. Usually I will tell them that once I see the healing, and the wires are removed, which is about 6 to 8 weeks, I will let them start passive more aggressively at that time. But my usually is, hey, do the motion. Don't use it to force grip around things initially. And then after about 2 weeks or so out of the splint, start working on the passive movement and then adding strengthening and force grip. So.
Thank you. I also had another question. Sorry, lots of questions.
Mm-hmm.
I see a lot of these with my high school athletes, and they come to me and they're like, yeah, it's been like this for 8 months. It's been like this for 9 months. So I did a little research on my own and found that the figure 8 splint worked well for that 8-week protocol. Is there a time period where it's like too far gone and you're like, well, we can do the splint, but it's never going to go back?
Yeah. Have you seen success after the 6 or 8 weeks?
I have. I actually had a basketball player that came to me and said, hey, it's been like this for about 8 months. And I said, okay, let's do this thing that I read about. And she was a little bit more than that 10% drop on it, but it was functional and she had a lot more motion whenever we started the rehab after.
So I always usually push them to do the 6 or 8 weeks extension, splinting, or figure of 8, or whatever works, no matter at what time frame I'm seeing them. For me, I think you do get some improvement. I don't know if it's just because you're getting a contracture more of the joint, or if the tendon is actually healing at that point. I think you do. I think you still end up with a 10 degrees or so, flexion, but I do feel that even after the 6 to 8 weeks, I don't know if there's any good studies regarding that in terms of the long term. After treatment starting after 8 weeks, that'll be interesting. I'll have to look that up, but I don't think there's any good studies that I've seen about following patients who were treated after 6 to 8 weeks or whatever. But that'd be interesting to see. I think just anecdotally that they do get some improvement in the position of their finger. By that point, a lot of patients don't have much pain as is. So it's hard to convince some of these patients, hey, is it even worth doing that, right? So that's the hard thing. Hey, I have a flexion deformity. It doesn't affect me gripping anything. All right, either I live with it. Do I want to wear this splint for, 2 months or not, or just, hey, be okay with it. And it may be hit or miss if it works or not. So that becomes, I think, the bigger question. Is it functionally any improvement? I don't know. Yeah. All right, acute boutonniere. So boutonniere is a whole hour-long talk on its own. Let me see time-wise so we can get us moving here. So, just focusing more on acute boutonniere. So forced flexion of the PIP joint, usually a direct blow, landing on something, landing on your hand, common on hand-related sports, basketball, volleyball. I think something you'll If you can obviously see it, hey, I got a flexion deformity, I can't actively extend, great. Sometimes it's very difficult to get that, hey, is this really there? Are they holding it because it hurts in that flex? So Elson's test is a commonly described test. Kind of hard to do in the painful setting, but something to try, where you ask the patient to hold the finger kind of flexed on a surface. So you'll use a table, edge of the table to flex around. You'll tell them to resist your pressure, resist PIP extension. And then at that time, you examine the DIP joint. Typically, it should be loose, because if your central slip is intact, and it'll be tight if it isn't. And that tightness is obviously because of the pull of the lateral bands is occurring. And so it's occurring through the force through the lateral bands, and then instead of through the central slip, and those attached on that distal phalanx. So that will tighten up the DIP joint, okay? All right, next slide. So I just threw this out there, a little bit of just, I know no one wants to get into the anatomy, but important in boutonnieres in general, but description of this, it's a complex structure. We talk about lateral bands a lot. Lateral bands, come from a combination of the interossei and the lumbricals attach on the radial aspect to as well to them. They help extend the DIP joint with a central slip injury in a more chronic fashion. Typically, you'll see the lateral bands will sublux volar because you can get this kind of boutonniere deformity from multiple reasons, including some inflammatory conditions, etc. As they sublux volar, then you can imagine how they are creating a force which creates flexion on the PIP joint, hyperextension on the DIP joint, and the force naturally of how the lumbricals would work, the lateral bands would work, changes with these pull if things aren't held in place, basically. So you're disrupting how these things are being held in place, and that causes weird deformities and different forces across the joints. A whole lecture on itself if you ever are interested. So next slide. So commonly non-operative, full-time extension splinting, PIP joint. I usually will do 6 weeks full-time. 4 weeks, and then transition to nighttime. Depending on clinically, I see them back at 4 weeks. I'll look at how their fingers look clinically, and sometimes I will do 2 additional weeks before I transition them. The important thing here is moving the DIP joint still, as the PIP joint is held in extension. Next. The surgical treatment is, for me, if you have a good tendinous structure at the end and you can get a primary repair, great. I end up usually doing some sort of anchor supplementation, which is putting an anchor in the middle phalanx, tying that down. Sometimes I'll incorporate the anchor into a repair, that even with the tendons being involved there. So I'm able to get some stitches in the tendon and use an anchor to hold this straight. It is pretty rare that I'll put a wire through the PIP joint. You will see this sometimes if you get a subluxation of the PIP joint. That can be a pretty significant trauma it takes to do that. We will see that sometimes. You get a volar dislocation of the PIP joint, which is rare, where you get complete trauma and this volar subluxation. Then we want to get that joint space obviously well aligned. There are all sorts of reconstructive techniques that we could go into. I kind of focus more on the acute PIP, the central slip injury here. So next slide. After surgery, non-operative rehab, we splint fully. then move the IP joint. I guess we talked about this already in the other slide, but after 6 weeks, blocking and increasing 30-degree increments. Next. Surgical. So surgical, here, the key thing to rehab for surgery is appropriate exercise splints. So I think the basic thing, if you want to take anything from all of this, there's, a lot of time frame, a lot of numbers, a lot of splinting, is we want to start extended. We want to allow them to move quickly with any sort of repair we do, which in a boutonniere, I let them start doing about 30 degrees pretty quickly, and then advance that after about 3 to 4 weeks. We slowly advance that using sort of different blocking type splints. Resting splint, usually extension, and then you get exercise splint to help this. At about 6 weeks is when you start worrying more about lags. 4 to 6 weeks, start splinting for that, getting them up extended at night to try to get them fully straight if they have a lag. And with repairs by 6 to 8 weeks, I have started passive movement, strengthening, and getting them to start slowly gripping around things. I will tell you a lag is a big issue here. That's our biggest thing when we start repairing these. And that's why we really look out for that at 4 to 6 weeks, getting a lag. I have the boutonniere deformity is a hard thing to treat sometimes. I will tell you joint stiffness is a big thing, especially in the small finger. When I see it, it is, I will try to splint that much faster than thinking about surgery for the small finger. I have, felt, I think a lot of it's just size, getting a good repair of that tendon. It is very flat at that in that area anyways. Getting any sort of good locking stitch is very difficult. And especially in the small finger, it's pretty tough. So I really try to push for non-operative in the small finger if we can. The hard thing with boutonniere is getting it splinted and caught fast enough. In the athlete, a little bit different because obviously we have trainers and good trainers looking out for everyone. In general population, they usually present in a delayed fashion a lot of times, usually 3 to 4 weeks or longer after they've kept the finger like this and, oh, I have a sprain, show up. And that becomes a bigger issue because now we're dealing with contractures. So that's a big thing that we have to then modify our therapy to work on contractures a lot. So, all right. So de Quervain's, last thing here, this is more of an inflammatory thickening, chicken or the egg. Did the first dorsal compartment get thick and inflamed first, or did the tendon, and was there synovitis and inflammation around the tendon? We probably see more synovitis inflammation around the tendon in sports. And then difficulty moving through that first dorsal compartment. I think anatomical studies, cadaver studies, the two tendons to remember, APL, abductor pollicis longus, extensor pollicis brevis. Those are the two tendons that go through the first dorsal compartment. There can be multiple slips of the APL in a lot of people. And then there can be a septum. When we say septum, we mean there's actually a division inside of the tunnel that separates the EPB and the APL. And there are a lot of studies which will show that this exists in 40 to 60% of people, but that these patients may be more prone to failing injections and conservative treatment. Okay. And so it is something that we think is an anatomic variant that may predispose you to this. So next slide. Complaints, radial-sided wrist pain, twisting, gripping, Finkelstein's maneuver. So thumb in palm, passive ulnar deviation causes them to jump off the table usually. You'll notice a hump, some swelling pain in this area. I get a lot of patients who have a, I've seen it after injuries where they fall, they get the swelling localized here. Everyone's worried about a wrist fracture. Doesn't end up being a wrist fracture. It ends up really being the Lateral Bands tendinosynovitis, and more because of acute inflammation around the tendon, and just doesn't resolve. I've seen that quite a bit. Next. So initially, bracing, injections. I usually will only do one injection into Lateral Bands. If they don't see relief, typically I'm quick to discuss surgery, which we'll talk about. My thing with immobilization, I don't mind doing an initial period of about 2 weeks, especially if it's acute. But after that, I want them moving. I want them stretching. I will tell them to immobilize or use certain braces for certain activities, if they're gripping, lifting, doing stuff for an additional 2 weeks. But I have a hard time telling patients to immobilize completely for 6 weeks with this. I think tendon gliding is important. And, I think that we have to keep that tendon gliding, or then they end up with multiple issues, which include stiffness and include not moving that thumb at all, and regaining that motion is a big, big problem. So next slide. So surgical release, we make an incision. This is obviously a very extended incision for purposes of anatomy, but make an incision, identify the tendons. The key here is must look for the septum. So you must find both tendons, the EPB and APL, and make sure that you have released them completely in the area. It is, and I have done a revision surgery where patients have had a Lateral Bands release and they continue to have symptoms, and it's because the EPB tendon was not released when the patient had it the first time, and they continue to have symptoms. And so that is a known complication of surgery when that is not looked for. So that is the number one reason why people get continued recurrent symptoms. So, okay. Postoperative, this is a much simple rehab, which a lot of patients here, I don't even send them to therapy or rehab, or it's done with the trainer. They don't need to go to formal OT because I don't think the special braces are needed, like a lot of the stuff we've discussed today, which literally they have a soft wrap when they leave surgery. They take it off in 3 days. They can move immediately. They can get the incision wet when they take the wrap off. Once the incision is healed, really, I let them start doing whatever they want and tell them go forward as it feels better. Yes, is everyone going to return at 4 to 6 weeks? Probably not. There will be some patients still feel uncomfortable given what activity they need, but usually most people by 6 weeks are doing most of the things they want to be doing. So. All right. Well, feel free to email me any questions, or if anyone has questions on this slideshow in this presentation, let me know. Mindy. Next. All right, this is contacts of all our therapists of Allison, Ronnie, and Mindy. All right.
Yes, so you can call me with anything. If you have any troubles or you need to get into his office, I can always get you in. If you have any questions, I can kind of help be that middleman as well, or you can always reach out to him too. But if he's in clinic, sometimes I might be a better option to catch him in between cases or something. And not just hand and wrist stuff. I'm here for everything else too. We have lots of other surgeons in his office that see everything. There's not too much they can't see or treat.
Yep.
And they have therapists as well, so we can get you into any of our Baylor Scots, or all their offices have therapists. So they've got some in Wiley, Rockwall, and Forney as well. So just reach out if you guys need anything.
Let us know if we need anything. If you ever need anything, so give us a ring. Okay.
Awesome. Thank you so much, guys. It's a great presentation. I really appreciate the work that you put into it. I will send this out to everyone as I typically do. We are recording this, so I'll send them the link for the video now that we have access to that. We have 7-day chunks. And then I'll also be sending it to some of our high school athletic trainers that have expressed interest, because we do see so many of these in our clinics and want to make sure that we're giving the best care for our kiddos. All right, if there are no other comments or questions, I'll go ahead and let you guys get on with your day. Thank you again, and be on the lookout for that email.
Awesome. Thank you. Thanks, everyone.
Thanks, guys. Bye-bye.